Welcome to Better Sex, where you get the information and inspiration to create and enjoy your best possible sex life. Join your host, sex therapist Jessa Zimmerman, as she brings you expert guests, helpful tips, knowledge, and strategies to improve your intimate relationships. And now, your host, Jessa Zimmerman.
Hey, welcome back to the latest episode of the Better Sex Podcast. I'm Jessa, and I am here recording podcast interviews today. I tend to batch these and talk to lots of interesting people all in one day, and then sort of dribble them out in a weekly release for your benefit. And I'm so glad you're here partaking with me. Another thing that I do on Mondays when I'm podcast recording is work on my online course. You probably know I wrote the book Sex Without Stress, released in 2018, and I'm developing that into a pre-recorded online course to support people that want to go through that process, because the book was intended to be sort of a do-it-yourself program that takes you through the whole thing I do with couples in therapy, so that everybody could just, for $20, you could have this resource and you could do this whole thing on your own. But it's actually really hard to do on your own. So this is my attempt to offer support and structure to people that want to move through the process, or people that maybe don't learn through reading as well as they do through audio or visual, and to give some structure and, homework assignments and keep people on track, and then to have access to some answers and support as they move through it. So that's another thing I've been doing today, which is really fun. If you're interested in that, you might just keep your eye on sexwithoutstress.com, because I think the first formal release will be in the fall of 2019. So depending on when you're listening to this, it might be right around the corner, or maybe it already happened, but you can learn more there. Today, I'm revisiting a topic that I've covered, I guess maybe in a couple different ways so far, but I'm going to come back to it. We're talking about menopause again, but today I'm talking to a physician who runs a menopause clinic in Seattle. And I've come back to it in part because she offers a unique treatment in addition to hormone replacement therapy for things like hot flashes, or local topical hormonal treatment for vaginal symptoms. She also is a proponent of a very specific laser treatment that can rejuvenate the vaginal tissues. And that's not something we've talked about on the show before. So we're going to cover the whole gamut of, what is menopause? What are the kinds of symptoms? How common are they? What are the whole variety of treatment options, including, herbal supplements and things like that. But then she's going to get into this laser treatment. And of course, none of this is medical advice. You need to find a provider, but this is really a wealth of information for you if you yourself are in menopause, approaching menopause, know somebody who may be in menopause someday. It could be useful. Hope you enjoy it. Rebecca, thank you so much for being with me today.
I'm happy to be here.
So, it's all about menopause. All about menopause today, at least, especially as it regards sex. So, could you start just by defining, what is menopause and what's happening physically?
Sure. I'm happy to. So, the definition of menopause is the period that starts 12 months after your last menstrual period. So, there are a couple different phases of menopause, as I like to tell women. There's perimenopause, and that's when women start noticing the irregularity in their periods. They start getting the hot flashes and night sweats and symptoms like that. And then once that period stops, in 12 months, you're officially in menopause. But I really sort of start thinking of menopause as that 12 months after that last period.
Okay.
And then the hot flashes, night sweats, symptoms like that tend to continue for 1 to 5 years into menopause. But what women notice after the menopause, so after that 12-month period, is they start to get vaginal symptoms if they're going to get them. And those don't occur in the perimenopause because you still have some estrogen around here and there as you're having your irregular periods. But once that estrogen is well and truly gone in the menopause, then you start to notice the vaginal symptoms.
Okay, so are you saying that if women are going to have vaginal symptoms, they're going to show up pretty quickly into menopause?
I usually tell women the worst of the vaginal symptoms are going to show up by about 2 years in.
Oh, okay.
It doesn't mean they can't happen later. And what I see with women who get them later on in the menopause is that they were very sexually active early on, and then they stop, and then they try to go back.
Yeah, I there is some truth to this whole use it or lose it thing, isn't there?
There really, really is some truth to that, in the sense that it does tend to keep the tissues more elastic.
Okay.
And, a little bit of injury now and again does actually help promote healing in those tissues. And, it just keeps them a little more collagenated and elastic and lubricated.
Okay. All right. I guess we'll get to that when we get to recommendations, but it sounds like, continuing to be sexually active in some way or another would be very useful.
Yes.
Okay. And it's the change in estrogen that's responsible for the physical changes?
It is. So vaginal tissues are very estrogen sensitive. And when you go into menopause, your ovaries stop really producing much estrogen at all. There's a tiny little bit that's still made in the body through the fat cells, but it's really minimal. Women in menopause do continue to make some testosterone from their ovaries, and that's important because that does help vaginal health a little bit.
Okay.
So that women who have lost their ovaries for whatever reason, whether surgically or they've had to be removed, tend to suffer just a little bit more with vaginal symptoms because they don't have that testosterone to help them.
Okay.
But it really is that loss of estrogen in the menopause that starts the vaginal symptoms.
Yeah. Okay. So, menopause is a natural part of life, right? It's not an emergency or something really going wrong.
No, it's 100% natural and normal.
Right. So why would somebody seek medical treatment? Like, when is that advisable? When is it not?
So what I tell my patients when I see them in my menopause clinic is that menopause is natural and normal, but it comes with associated symptoms that can disturb your life. So if the symptoms of menopause are causing you distress, you should see us because there are things that we can do. It's not that they're abnormal, but sometimes there are things you can't live with, and that's okay.
Okay. So what are the kinds of things you're going to hear from people coming in to see you that, what's happening that's disturbing their life?
I really see a combination of two sets of women. I see women who are suffering from the sort of systemic symptoms, the hot flashes, night sweats, lack of sleep, issues like that. And then I also see a subset of women who are suffering primarily from vaginal symptoms. So itching and burning on a day-to-day basis that they just can't get control of. Often they'll describe it as every time I have to use the bathroom, the toilet paper feels like shards of glass. Pain with intercourse is a huge issue. Affects probably about 50% of women in menopause.
Wow.
With that lack of lubrication and lack of elasticity. And then I often see women who are seeing increasing yeast infections or bacterial vaginosis or even urinary tract infections from the change in pH and the change in bacteria that live in the vagina.
Oh, okay. So that's another change, is the pH is changing. So sort of the microclimate or microbiome is
the microbiome absolutely shifts in menopause. The pH changes. The estrogen keeps the vagina very acidic. And so that just shifts in menopause, which, again, for many women doesn't bother them at all.
Right.
But the bacteria that will live there will be slightly different because the lactobacilli that we all think of as the great bacteria in the vagina really need that very, very acidic environment. And if the vagina isn't at that pH, they can't live there. So what you see instead are sort of a combination of different bacteria that resemble the bowel flora, as we like to call them, much more. And that's reasonable. The place where the bowel flora come out is right next to the place where the vagina
right. Not a huge leap, so to speak.
It is not a huge leap. And nor in premenopausally, the pH is not hospitable for those flora. Postmenopausally, it's more hospitable.
Wow. Okay. So first, how common is it? I don't know what kind of research there is. What percentage of women are going to have these different kinds of symptoms in a problematic way, I guess, because the changes happen to everybody.
Right.
But how common is it to, have hot flashes and lack of sleep? And how common is it to have that, sexual pain or yeast infections?
So the hot flashes and lack of sleep is a big spectrum. Most women will experience some hot flashes. But for many women, it's just not problematic. They happen once or twice a month or maybe once a week, and it's manageable. Problematic hot flashes, so multiple times a day, or disturbing sleep, or really impacting lifestyle, probably happens in about 30 to 40% of women.
Okay.
And those are women for whom a conversation with your doctor is imperative, because there's lots of things we can do, both hormonally and non-hormonally, at least try to minimize those symptoms.
Okay.
In terms of the vaginal symptoms, what we know is that while everyone's vagina will change, only about 50% of women experience detrimental symptoms from that change.
Okay,
So,
which means that 50% of women can go on not having detrimental changes. I mean,
absolutely. The
having
changes
sex.
happen to everybody, but the symptoms don't happen to everybody.
Okay.
So if you're not having the symptoms, you don't need to treat with anything.
Right.
The only thing I say to all women in menopause is that lube is for everybody.
Yeah.
Because you're just not going to be as lubricated in menopause as you were before.
Right.
And if you want to try to prevent bad symptoms and bad experiences, then use a lot of lube and use a good slippery silicone one that's not going to get sticky over time.
Okay. Do you have
a favorite? Everyone in menopause to try.
Do you have a favorite?
I have a few. So it depends on if you're using it with condoms or not, because that's important. You can't use oil-based lubes with condoms. So for women who are in a monogamous relationship and feel comfortable having intercourse without condoms, then I often recommend either coconut oil, which you can buy in the grocery store, or Uber Lube, which is an oil-based lube. Okay. For women who are using condoms or just don't like those two, find them messy, because oil can stain sheets.
Right.
I often recommend the hybrid personal lubricant on Geneve.com, because it's nice and pH balanced and has some silicone in it. And that's GENNEVE.com. I write content for their website. I don't profit from their lube.
Okay. Okay.
There's also one called Please that you can get on Babeland Toys.
Okay. Great. Good to know. I don't actually know most of those, so.
Yeah. Those are ones that seem to be very well pH balanced, don't have extra scents or ingredients or anything that's going to irritate anyone.
Mm-hmm. Okay. So what are the treatment options available? And I don't know if you want to take the hot flashes separate from vaginal symptoms.
Yeah, I will, actually, because we do treat them separately and differently. So in terms of systemic symptoms, and by systemic symptoms, I mean hot flashes, night sweats, even some of the mood stuff, although mood we tend to deal with slightly differently. The main treatment is hormone therapy, but systemic hormone therapy. So it's the one that's most proven to work.
Okay.
And by that, I mean a pill or a patch. And it's estrogen plus or minus progesterone. You only need progesterone if you still have a uterus.
Okay.
And I know a lot of women worry about estrogen therapy because of the Women's Health Initiative that came out years and years ago. What that study was designed to look at was if giving women in menopause estrogen or estrogen and progesterone if they had a uterus would help with cardiovascular events. So they took a lot of women, they took a huge number of women, and randomized them to start or not start estrogen. But they randomized them often at ages where they've been in menopause for 5, 10, or 15 years. Mm. So not how we prescribe estrogen to our patients. We prescribe at the transition when they're having symptoms.
Right, because you said the hot flashes tend to subside.
They tend to dissipate,
yeah. Okay.
And so not only did they not show any benefit cardiovascularly, and there are a lot of reasons for that, but the thing that everybody heard was that it can cause breast cancer.
Right.
And that was in the subset of women taking both estrogen and progesterone. And the absolute increase in risk was very small. You can see it because you have to remember 1 in 8 women will get breast cancer in their lifetimes. That's the base rate. So if you increase it even just a little bit, it looks like a huge increase because so many women get breast cancer anyway.
Okay.
The other thing that we know from that study when they went back and looked at it more carefully is that women who had not been in menopause more than 5 years didn't get that increase in rate. So there's probably something very significant about starting hormones after you've been off them for a long time.
Okay.
And so there are actually ongoing studies with women who started hormones immediately at menopause and looking to see if that breast cancer risk holds out, because that's much more in line with how we actually prescribe them.
Right. Okay. That makes sense.
That being said, I would never use estrogen without a progesterone in someone with a uterus, because I can guarantee that I can cause endometrial cancer or cancer of the lining of the uterus with unopposed estrogen.
Oh, okay.
So that's why we give the progesterone. It's very important.
Okay. So it's not just available to people with a uterus. It's like you need to
yes,
do both.
You need to take it. Yeah. But you don't need to take a lot of it, and you don't need to take it very often. And there are lots of different ways that we can do that are probably more detailed than we need today.
Okay.
But hormones will take the hot flashes away.
Okay.
If, for whatever reason, hormones are not an option for a patient, then there are other things we can explore. I am always happy to explore herbal remedies as long as they're ones that I know are safe and not harmful. And the reason I say that is there are a few herbal remedies out there on the market that are highly estrogenic.
Oh.
And can be just as dangerous as taking unopposed estrogen pharmaceutical grade. And so I try to steer people away from those.
Okay, because again, if they have a uterus, they're going to be in trouble. I mean, their likelihood goes up. Yeah.
But also, if they're worried about taking estrogen, then they shouldn't take these herbs either, because they're just taking estrogen in an unregulated form.
Okay. Yeah, it makes sense.
So there's some herbal remedies like black cohosh, raspberry leaf, some dong quai, which don't have great data for effectiveness, but also if you get them from a reputable source, aren't going to be harmful to you. And if they work for you, then great. I have no objection to that. And what we find with those herbals is that they're at least 25% effective. Of course, the placebo effect is also about 25%.
Right.
But I don't really care if you're getting a placebo effect if you feel better.
I've always thought it's kind of a shame that we dismiss the placebo effect, because that's pretty amazing.
No, it's great. And the funny thing that, there was a study that came out about a year or two ago that showed that if you give somebody a sugar pill and tell them it's a placebo, it still works 25% of the time.
You're kidding. I didn't know.
No.
Wow.
So it doesn't matter if you even know it might be a placebo effect. It may still work for you.
Wow. Okay.
Some women find relief in acupuncture. Again, probably about the same rate as placebo effect, but if it works for you, then fantastic. It's not going to hurt you.
Okay.
And then there are some studies with antidepressant medicines. So the SSRIs, like Prozac or Zoloft, can have some benefit on hot flashes. And then there's one hypertension medicine called clonidine, which can also have some benefit with hot flashes. So those are some of the things we try in women who can't take hormones for those symptoms.
Okay. And is there much research in these alternative
There is ongoing research. None of them are fantastic. You know, they have some effectiveness. They reduce the frequency of symptoms. They don't take them totally away like hormones do.
It just seems like there wouldn't be the volume of research on things that weren't pharmaceutical, but,
No. Well, no, there have been some very good studies on the herbal remedies and the acupuncture.
Okay.
And actually out of Western medicine tradition. So one of the studies was done by a physician here at the University of Washington who was comparing them to placebo. Because that's really what we need to look at is what is the placebo effect? What is the herbal effect?
Right. Okay.
And then in terms of lifestyle changes that women can make, red wine tends to be a trigger for hot flashes. So reducing your consumption of red wine.
Well, that's not good news.
I know, because we like red wine. White wine doesn't do it, but it probably doesn't have health benefits for red wine. Caffeine can be a trigger, so something to think about. And then what we find is that regular exercise tends to, over time, reduce the incidence of hot flashes.
Okay.
It's not, run a mile, get fewer hot flashes. It's, exercise, moderate to, vigorous exercise 3 to 5 times a week for several months, and they seem to reduce.
Okay.
So it's much more of a large lifestyle change.
Right.
And then the last thing I talk to my patients who have night sweats, I'll often talk to them about environmental things that they can do. Bamboo sheets. There's something called a chili pad, which basically cools off half the bed. And makes it colder. There are fans you can get to blow up from your feet under the sheets. Those types of things may help for some women. And then daytime hot flashes, one of the things women often find helpful is getting a neck pack that they can keep in the freezer. So if they feel one coming on, they can put it around their neck.
Okay.
So that's sort of the hot flash night sweat treatment.
Okay. It's Jessa. I'm just taking a quick break in the middle of the show to let you know about some guides I have available to you if you're interested. So desire discrepancy is the phenomenon where one person wants more sex than the other, and it's actually universal. This is always true, at least over time in a relationship. So nothing is broken if you have desire discrepancy, and yet it is so easy to get caught in dynamics that are really, really difficult when this is happening. You fall into what I call the traps of desire discrepancy, and then you end up at odds with each other and almost polarized and not navigating this difference in a way that works for both of you. So I have written up guides, one for the lower desire partner and one for the higher desire partner, about what these traps are and what you might do differently. So if you would like to download these, they are totally free. You can go to bettersexpodcast.com/desire and download them. I hope they help. Back to the show.
When we get to the vaginal symptoms, the key with the vagina is that if the vagina is what's suffering, you need to treat vaginally.
Okay.
Treating systemically often doesn't reach those tissues very well.
Okay.
So when we're treating for vaginal symptoms, again, my first step is always with making sure people are using adequate and good lube.
Right.
You can use it if your symptoms are mostly the day-to-day, just feeling itchy or dry. There's some great vaginal moisturizers on the market, whether it be Replens, which is over the counter at the pharmacy, or Geneve.com also makes a vaginal intimate moisture, which is great. Also pH balance. Those can be very soothing day-to-day. Some women find that using a little bit of coconut oil just inside the vagina day-to-day is soothing, but again, can stain your underpants. And then if it's just externally, I often have my patients put either Aquaphor or CeraVe. These are ointment moisturizers you can buy in the pharmacy, used often for eczema, just on the external vulva. And those can be very comforting and moisturizing.
And did you just say that the one for the moisturizer from Geneve or Replens, those are pH balancing, or they can adjust?
They're pH balanced, so they're not going to further alter the pH of the vagina.
Okay, but they're not going to bring it back to the acidic environment that we were used to.
No, they temporarily get it a little more acidic, but that wears off pretty quickly.
Okay.
There have been medical trials of hyaluronic acid and trying to reset the pH of the vagina, but that also tends to wear off and doesn't seem to be of huge benefit.
Okay.
And then the next step is always using hormone again, so estrogen. What I find is that there are several ultra low dose preparations where you're not taking the risk of getting into your uterus, so we can use them without progesterone. So women often feel more comfortable with that.
Okay.
Because they're not having to think about progesterone and that breast cancer risk.
Okay.
And those come in just a variety of forms. There's a ring, there's a tablet, there's a little gel cap where it's mixed in coconut oil. I think all of those are great for different women, and we sort of discuss which one would work best for them, depending on their symptoms and the ease of use. And then there's also estrogen cream, which is higher dose, and so there you would have to use progesterone if you still have uterus. And that may be the next step if those really ultra low dose ones just aren't enough. There are also two products on the market that I don't use very much because they're very expensive and I'm not sure they have a whole lot of added benefit over just straight up estrogen. One is a suppository you use daily that has a precursor hormone to estrogen and testosterone.
Okay.
And so it goes into the cells and is converted into estrogen and testosterone. In theory, it works fine. It's just you have to use it every day, and it tends to get expensive. And then the other is actually a tablet you can take, which is what we call a selective estrogen receptor modifier. So the one most people have heard of is called tamoxifen. That's given to women with breast cancer. Mm-hmm. This is the same type of medication, but each one behaves differently in different tissues. And this particular one called Osphena seems to help the vaginal tissues, but not stimulate the uterus. So for women who really can't imagine putting something in their vagina or who are older and can't reach, I will often try that.
Okay.
And then the one other thing that I offer in my clinic, but is not always used in every OBGYN office, is laser treatment for vaginal atrophy.
Yes.
I use the Mona Lisa Touch laser. And I started doing that in 2016 because I have a huge population of women with breast cancer or other hormone-related cancers who can't use estrogen as an option or won't.
Okay.
And so they were really struggling with just moisturizers.
Yeah. Yeah.
And so what the monolethal laser is a carbon dioxide laser. And you basically cause tiny little micro injuries in the vaginal and vulvar tissues, which your body then rushes in and heals. And in healing, that tends to reset it to a more premenopausal state. So the pH goes down, the tissues get thicker and more elastic. The reason I opted to start doing it is there's pretty good what we call outcomes data out of Europe where it started. And what I mean by outcomes data is, they treat 50 women and then follow them at 3 and 12 months.
Okay.
And what that data was telling us over 10 years was that women, about 92% of women got a pretty good result from the laser. And then last year, they actually published the first comparative study, which was very exciting to me because I wanted to see how the laser compared to estrogen. Because that's really sort of the gold standard. And what that study showed, it was a really neat study. They basically brought women in and then randomized them to one of 3 groups. And everybody in the study was blinded, both the doctors and the patients. And the first group got a real estrogen tablet and a fake laser treatment. And the second group got a real laser treatment and a fake estrogen tablet. And the third group got both. Real.
Right.
And what they showed was that the laser and the estrogen tablet, if you got one or the other, both improved their symptoms. And, one worked a little better in some parameters and one worked a little better in other parameters, but about equivalently both improved outcomes. But if you did both together, they actually got much better. So that's exciting for me to help counsel my patients who aren't totally unable to use estrogen. The downside of the laser, because it doesn't have a lot of side effects, but the downside is that it's very expensive because it's only FDA cleared, which means safe, but it's not FDA approved for vaginal use. So that means that insurance companies consider it experimental and they don't pay for it.
Okay.
And that's a real bummer. And I've been advocating with the company that makes the laser to finish the FDA approval process because I think they have the data that they could get through it. But they need to do it so they can argue with insurance companies that it should be covered.
Right. Now, if you've started using the laser because you've got so many clients that have breast cancer and can't use the estrogen, so it's good to know it's kind of comparable to estrogen treatment. But what about, are you using a combination for those patients that can tolerate the estrogen?
Yes. So I do have a decent proportion of my patients come to me because they're using estrogen and getting some effects and they are hoping they can get more.
Okay.
Or the other population I see are people who have used estrogen to good effect and find it messy or frustrating or expensive or just don't want to do it every week. And they want to do the laser instead. Mm-hmm. So often what I'll do then is I'll use the two together through the treatment period and then say, hey, if you want to taper off the estrogen and just try to see if the good benefit holds, then that'll work great.
Right. Yeah. And does the estrogen treatment, I think you said the laser adjusts the pH?
Yes, it does, actually. So one of the early, estrogen will too.
Okay.
And one of the early studies they did with the laser was they actually did the laser treatment, and at 3 months they checked the pH and the bacteria that were living in the vagina of the women who got the treatment. And they showed that the pH went down appropriately and that the lactobacilli counts went back up.
Okay.
And there are old studies with estrogen that show the same thing.
And is there any place for testosterone treatment with menopause?
That's a really good question. I wish we knew.
Okay.
The research is just not great on that. Okay. I do periodically use a little testosterone for my patients with good counseling. I think the issues we have with treating with testosterone are, one, we don't really know definitively what normal female levels are. And they're very varied. I think we have a much better handle on what normal male levels of testosterone are. I think that we don't recognize the fact that there is still testosterone around in menopause being made by the ovaries. And while that level is, the actual level of testosterone made by the ovaries is lower in menopause, so is the level of sex hormone binding globulin, which is sort of a molecule that lives in your bloodstream and holds testosterone so it can't be used. So the actual free testosterone level isn't all that lower in most women in menopause than it was menopausally. So I'm not sure what adding testosterone really is doing, maybe other than somewhat of a placebo effect. That being said, in women who don't have ovaries, there may be a role for it.
Okay, yeah, I guess that was my question. If women didn't have ovaries, if
one doesn't have ovaries and you are not making testosterone, there could actually be a genuine role for it. Okay. We always have to balance that with the fact that testosterone has side effects. It's an anabolic steroid, basically. So, we have to make sure we keep the levels low enough that we're not causing risk, cardiac disease. When women take testosterone, their cholesterol profiles change, and they look much more male in that sense.
Right.
And, gives them a higher cardiac risk, theoretically. And it has physical side effects. If you give too much testosterone, women will grow facial hair and their voices will drop. And it can be very acne-inducing. You can even get clitoromegaly, so the clitoris becomes very enlarged.
Yeah.
It takes a decent amount of testosterone to do that.
I would imagine, yeah.
The patients I've seen that happen most commonly are people who are given those pellets that are becoming a huge fad. So these are little pellets of testosterone that are implanted under the skin. And they're very high dose, and they don't release at a regular rate because it depends on how deep they're implanted and what tissue exactly they're in and how close they are to a blood vessel. And they can't be removed. So if you do get side effects, we can't stop it. I tell my patients to stay far, far away from those. If we're going to try testosterone, we do it in a topical formulation. But unfortunately, we have to compound it because the only topical formulations available pharmaceutically are for men, and they're far too high.
Okay.
So we end up having to compound it for women, which makes it a little less regular in absorption, but I keep the doses very low.
Yeah. Well, I suppose with all of this, you've got to consult with a knowledgeable physician, right? Like none of this is stuff to take lightly, even like you're saying, even the herbal supplements.
Even the herbal supplements. And, I'm really lucky. Over the years, I've found some amazing folks at Bastyr who really understand sort of the benefits and limits of what herbal medicine can do. And so they're very happy to talk about the fact that herbals can be a great first step. But if they don't work, then you may need to think about hormones and speak to an MD instead of a naturopath. Right. And I think that's really, out here in the West Coast, because I trained on the East Coast, so I never saw a naturopath out there. They don't exist. When I first got here, I thought it was going to be great because we'd have these other providers and we could talk about how we can complement each other's work. And I see so much infighting. And I think that frustrates me because what ends up happening is there are naturopaths out there doing things they really shouldn't be doing because they don't want to collaborate with MDs, and all naturopaths are bad because they don't want to collaborate with them. I think we could be much more effective if we were to work together and recognize what we can and can't offer within our own specialties.
Right. That's a point well taken. Where can people learn more about you and about your clinic?
Well, they're more than welcome to find me online, and my clinic name is RenewVagyn, sort of a cutesy name we gave it. It's RenewVagyn.com. And I've got tons of information about both Mona Lisa and menopause itself there. I do consultations with women on all sorts of menopausal symptoms and sexual function in menopause and the Mona Lisa touch. What I do warn women is that it's a relatively new clinic. I've actually been there since 2016, but as it's grown, I'm slowly making it to the point where I'll actually be instituting insurance contracts. Right now I do cash and a receipt, and you have to get reimbursed for a consultation. But I'm hopefully, fingers crossed, by September going to have full insurance contracts. So all that can be submitted directly to insurance.
Right. And you're in Seattle, as am I. Plenty of people.
I'm at the Swedish Crystal Medical Center.
Right. So plenty of people listening won't even be in Washington State, but they still may be willing, interested in checking out the website and learning a little bit more and then finding local resources. Yeah.
Use my website as a resource. Another resource, and I mentioned it earlier, I'm the director of health, and I write content for Geneve.com. That's GENNEVE.com. And that's a website for women in midlife and menopause. And we do medically valid and validated content and information, and it's all free.
Yeah. Great. Wonderful to point that out too. Well, thank you so much for taking the time for talking to me today.
Oh, I'm thrilled to do it. Thank you.
You've been listening to Better Sex. Please visit our website, bettersexpodcast.com, for show notes and additional episodes.
And that's a wrap for today. I really hope you enjoyed the episode. If you are enjoying the podcast, if some of this material resonates with you and you would like to make a difference and make sure that this keeps coming out in the world once a week, ongoing, there are a couple things you could do to show your appreciation. The first would be to go to iTunes and rate and review the show. That really helps us be found by new listeners when you review the show on iTunes. You can find a link at bettersexpodcast.com/iTunes. The other thing I want to invite you to consider is becoming a Patreon. For a small monthly pledge, you get some benefits. So for $2 a month, you get advance access to every single episode. For $5 a month, you get a chapter of my upcoming new book. And for $10 a month, I host quarterly get-to-know-you and question-and-answer chats over the web, and you get invited to that. I would love to have your membership in that, become part of the Better Sex family. You can find a link at bettersexpodcast.com/Patreon, which is Patreon. Again, thanks for listening. I'm glad you're here. Feel free to comment, ask questions, get in touch. I'd love to hear from listeners. Thanks.